Hi, welcome everyone. Thank you for joining. We'll give it a couple more minutes for everyone to come on. Hi, Dr. Sohaney. Just want to make sure that your mic is working and everything.
Hello, how are you doing?
Good. We can hear you well. Thank you. So when we kick off, I'll share the first slides and then I'll pass it over to you to share your slide deck. Hey everyone, we'll give it just one more minute for folks to join and then we can get started. Thank you for joining. Hey, hi everybody. I'm Mary Wozniak. I am a program manager with the National Kidney Foundation of Michigan. Very excited to see you all today. Thank you for joining. This is our fifth presentation for the annual Grand Round series about kidney disease. I'm going to go ahead and share just some general intro slides before I pass it over to Dr. Sohaney. Today we'll be discussing managing the common complications of chronic kidney disease, what to watch for, and when to refer to specialty. This is our accreditation statement. This will be shared with you afterwards by email as well. And I did just want to mention one disclosure from Dr. Sohaney. She is a consultant and advisor with Record Medical. In order to claim your CME credit, this will be open after the session is over. The activity code is on top. And again, this will all be emailed to you in order to claim credit if you're seeking CME or CEUs. For any questions, you can email Terry Walters. She just was not able to be here today. And please feel free to, unmute, ask questions throughout the presentation. I will also be monitoring the chat if questions come up, and we will have some time towards the end as well for Q&A. And I'd like to introduce Dr. Ryann Sohaney. Dr. Sohaney completed her internal medicine residency at Henry Ford Hospital, followed by a fellowship in nephrology at University of Michigan. She currently serves as a senior staff nephrologist at Henry Ford in Detroit, where she also leads the director of hypertension clinic and section head of the clinical research in nephrology. Her research interests focus on improving long-term outcomes after acute kidney injury. So thank you, and I will let you go ahead and share your slides.
Okay, can you see this as just one screen with the PowerPoint?
It's in presenter view for us.
Let me see. Okay, how about now?
Yep, that's perfect.
Okay. Thanks for joining me today. I plan to discuss managing complications of chronic kidney disease, what to watch for, and when to refer to a nephrologist. So today, our learning objectives are to recognize common complications of chronic kidney disease, including hyperkalemia, metabolic acidosis, anemia, and primarily cardiovascular kidney treatment interactions. Interpret key laboratory findings to guide management of CKD complications, and identify appropriate clinical thresholds for timely nephrology referral. So to quickly review, chronic kidney disease is diagnosed based on two tests: a blood test to determine GFR and a urine test to determine whether there's protein in the urine, most commonly using the albumin-creatinine ratio. It's very important that we combine these two tests in order to determine who is highest risk for progression and cardiovascular disease outcomes and to diagnose chronic kidney disease early. If your lab does not report the eGFR based on the most recent guidelines, you can always use an eGFR calculator. Also, an online eGFR calculator using the 2021 guidelines, you're able to use both creatinine and cystatin C if you're using this in order to estimate GFR. In some individuals, there are benefits to using both. For example, in somebody who is, say, a bodybuilder or more robust than an individual of their typical age, the creatinine may underestimate their kidney function, and so using a combined equation may be useful. On the flip side, in somebody who is frail, particularly a younger individual who's frail, their serum creatinine may overestimate their kidney function, and use of statin C can be beneficial in this scenario as well. In order to diagnose chronic kidney disease, we need abnormalities of kidney structure or function present for at least 3 months. So a single creatinine value that leads to a GFR below 60 does not necessarily define CKD, particularly if that most next value returns to normal. And there must be a marker of some sort of marker of kidney damage. An eGFR less than 60 that's persistent for at least 3 months, or a UACR above threshold, above 30 milligrams per gram, can both indicate chronic kidney disease. And hopefully you've seen this before. This is a heat map that we'll come back to a little bit later. And on this left side here, you see what's the GFR stage. And this is what most individuals are very good at diagnosing. Usually we start with chronic kidney disease stage 3A. But an individual with 60 to 89 can also have chronic kidney disease stage 2. And somebody can also have chronic kidney disease stage 1 if their GFR is above 90 and say they have a solitary kidney or they have albuminuria. And so when we look at the albuminuria stages, we have A1 for less than 30, 30 to 300 for A2, and greater than 300 in A3 grades. And again, what I want to point out here are those who are increased risk of progression and poor outcomes are those who, when you look, say, chronic kidney disease stage 3A, typically we would think of this as mild, but if somebody has more than 300 milligram per gram of proteinuria, they are more likely to have progressive kidney disease and poor cardiovascular outcomes. And so these individuals may already warrant referral to a nephrologist. And our goals of care in those with chronic kidney disease are to ensure that they have a diagnosis, that we slow decline in kidney function, but also that we modify cardiovascular disease risk factors. And that's what we'll spend a lot of the time talking about today. There are many complications of chronic kidney disease. Almost all individuals with chronic kidney disease have hypertension. Half of those who have chronic kidney disease die from cardiovascular disease before they ever require dialysis. Hyperkalemia at advanced stages or in diabetic kidney disease is quite common. Metabolic acidosis, anemia, secondary hyperparathyroidism, hyperphosphatemia, and hypocalcemia. We won't talk about all of these today, but we will talk about the first half. And what I'll spend a lot of time talking about is cardiovascular disease modification. Again, cardiovascular disease is very common in those with chronic kidney disease. We see an increasing burden of cardiovascular disease and cardiovascular events with reducing eGFR. These are age-adjusted risk of cardiovascular disease. You can see clearly risk increases with declining kidney function. And when we are looking at predictors of cardiovascular mortality, both urine albumin creatinine ratio and GFR are greater predictors of cardiovascular disease mortality than even diabetes or cholesterol, smoking, or blood pressure. And the greatest predictor of risk of cardiovascular mortality is actually a combination of eGFR and urine albumin creatinine ratio. And another way to look at this, again, is with the heat map. On the previous heat map, we were showing the chronic kidney disease stage and risk for progression of chronic kidney disease, and when one should refer to a nephrologist. Here is a series of heat maps from Morgan Graham's, and I'm only going to point out a couple of these. The cardiovascular mortality and kidney failure with replacement. And I want to show these because we can demonstrate that even those with a normal GFR, so GFR above 90, but with albuminuria greater than 300, the relative risk of cardiovascular mortality is significant, even before the GFR begins to climb. In fact, albuminuria seems to be a bigger predictor of cardiovascular mortality than it is of need for end-stage renal disease progression to end-stage renal disease requiring renal replacement therapy. And when I'm talking to patients about their kidney disease, I'm not just talking to them about slowing kidney function decline and avoiding dialysis, because many of my patients will never need dialysis that I meet in the nephrology clinic. I'm talking to them about reducing cardiovascular disease and protecting their heart as well. Kidney disease with diabetes both increase cardiovascular disease risk, and individuals who have both of these are at greatest risk, is essentially what I'm showing here. Therefore, chronic kidney disease is a disease modifier. And there are many ways to target cardiovascular risk reduction. Anything that reduces the protein in the urine and reduces progression of kidney disease has also demonstrated some cardiovascular protection, which makes sense based on the previous data that I showed. It's also important that we manage hypertension and other metabolic risk factors, including weight management and glycemic control. And so we have a lot of tools in our tool belt that we use as nephrologists and also that you're using in primary care as well. There are many different strategies to reducing protein in the urine. This has been pretty impressive to me. I remember when I was first going into nephrology, people asking me, why would you do that? All you have are ACE inhibitors. And I feel like the number of agents that we have now to reduce albuminuria and slow progression of kidney disease continues to increase. In fact, there's many trials ongoing right now with some promising therapies that may even be added on to those that you see here. And so anybody who can tolerate an ACE or an ARB who has CKD should be on one. There are also some diet measures that we can use by restricting sodium intake. Weight loss can also reduce albuminuria. Possibly a low animal protein diet, blood pressure optimization, SGLT2 inhibitors. This is a class effect, all SGLT2 inhibitors, and then mineralocorticoids. And the strongest evidence here is for finerenone in those with kidney disease. In fact, we should avoid use of spironolactone if they're not already on it in those with a GFR less than 30. And so these therapeutic options, in many patients should be requirements, including an ACE or an ARB. Preferably, I start with an ARB as opposed to an ACE inhibitor, but this is for two reasons. One, patients don't get the cough that leads to significant discontinuation of ACE inhibitors. And there are different mechanisms with ACE inhibitors and angioedema. And I have found that when individuals have angioedema with ACE inhibitors, they're often reluctant to start an ARB, or the pharmacy is reluctant to start an ARB. So I prefer to start with an ARB, but either are acceptable. SGLT2 inhibitors, it is a class effect, so it does not matter which you choose. I choose what insurance covers, and now dapagliflozin is generic. Non-steroidal mineralocorticoid receptor antagonist, the only one on the market is finerenone. The brand name for that is Kerendia, and glucagon-like peptide 1 medications. So starting with ACE or ARB, these are indicated patients with albuminuria greater than 30 milligrams per gram with or without diabetes, or just chronic kidney disease, and should be continued in those unless the serum creatinine rises more than 30% within 4 weeks of initiation or increase in dose. Some increase in serum creatinine is expected and shouldn't cause alarm. But if there's more than a 30% increase or 50% increase, then I do question whether there's something like renal artery stenosis that is occurring then. Now, the common question is, would withdrawal of an ACE inhibitor when an individual has advanced in CKD stages, say maybe their GFR is 12 or 20, is taking off that ACE inhibitor going to preserve that little bit of kidney function that they have left? And for a while, we used to see even some nephrologists would take off ACE inhibitors thinking that it would buy the individual some time before they need dialysis, purely for eGFR decline, not talking about elevations in potassium. And this was a really nice small study that was published in 2022. There were 411 patients with CKD 4 or 5. They all had been high progressors, meaning that their GFR had declined at least 2 milliliters per year over the prior year. And they had been on an ACE or an ARB for at least 6 months. And those who were randomized to continue, essentially half were randomized to continue an ACE and ARB, and the other discontinued. And there was not any difference in decline in eGFR over 36 months or need to start renal replacement therapy. Furthermore, we know that in those where ACE or ARBs are stopped with advanced CKD, there's a greater risk of adverse outcomes, particularly cardiovascular outcomes, MACE. And therefore, we should not be stopping ACE or ARBs purely with the intention that we'll preserve that little bit of kidney function, because it's not effective at doing that, and it increases cardiovascular events. So we should continue ACE or ARBs in advanced CKD associated with because of the association with cardiovascular health benefits. Continue even when the GFR is less than 30, and consider reducing dose or discontinuing when there's uncontrolled hyperkalemia despite optimal medical treatment or symptomatic hypotension. So every effort should remain to keep individuals on an ACE and ARB, and that's primarily because of cardiovascular benefit. SGLT2 inhibitors, again, class effect, they've all shown that they reduce progression of chronic kidney disease and reduce albuminuria. They also all have cardiovascular health benefits. Another potential benefit of SGLT2 inhibitors in those with uncontrolled hypertension is that we do see some lowering of blood pressure from baseline after initiation. In some studies, as much as like 8 to 9 systolic blood pressure from baseline. Now, we do need to consider that in somebody whose blood pressure is normotensive before initiating. Sometimes I'll reduce if they're on a thiazide, reduce or stop the thiazide before starting an SGLT2 inhibitor. But sometimes I'll use this with the expectation that also I may finally get a little bit better blood pressure control. And so KDIGO recommends that patients with type 2 diabetes, CKD, and an eGFR less than 20 start an SGLT2 inhibitor, and that it's reasonable to continue even when the GFR falls below 20, and it should be continued until no longer tolerated or dialysis is initiated. And then it's also indicated for those with non-diabetic kidney disease. In fact, in those with albuminuria and again, a GFR greater than 20 or heart failure, irrespective of albuminuria. And the same guidelines for discontinuation. It can be continued up until they start dialysis. As of now, there isn't evidence for continuing the medication on dialysis. It's not clear whether there's still cardiovascular benefit or not. I think that is something that could potentially change in the future, but many times patients with ESRD are not entered into trials. There's also non-steroidal MRAs. Again, the only one on the market is finerenone. You may know it as Kerendia. And compared to steroidal MRAs like spironolactone and eplerenone, there's a shorter plasma half-life. There's higher selectivity for the mineralocorticoid receptor. There's a lower incidence of hyperkalemia, although it does still occur, and there's less sexual side effects, and overall is better tolerated. There's been several trials now with finerenone and those with kidney disease. The first was Fidelio DKD, with DKD standing for diabetic kidney disease. This study was focused on the primary outcome of chronic kidney disease progression, need for dialysis, and sustained decrease in eGFR. And demonstrated that there was a renal protective effect of finerenone in those with a GFR greater than 25. GFR 25 was the cutoff, and they went up to 75. Now, Figaro DKD used a very similar population, wasn't exactly the same. They did also have diabetic kidney disease, although the GFR went up to 90 in those with albuminuria. And its primary outcome was cardiovascular death from cardiovascular cause or hospitalization from heart failure. And again, finerenone was cardioprotective. And so after this, finerenone was FDA approved for those with diabetic kidney disease. Now, earlier this year, maybe it was end of last year, there was the FIND CKD study was published. Believe it was this year. And FIND CKD was finerenone use in those with the GFR 25 to 90 with albuminuria. And these all had kind of different albuminuria targets based on GFR. But it was in those with non-diabetic kidney disease. And again, they demonstrated that there was a renal protective effect in those who have non-diabetic kidney disease. So finerenone should no longer be just relegated to those who have diabetic kidney disease. I've gotten a few patients covered for finerenone that don't have diabetic kidney disease, although I've had much better luck in those who have diabetic kidney disease, but I think we'll see an increase of insurers soon, I hope. So KDIGO recommendations. Now, these were before the FIND CKD study recommends that non-steroidal mineralocorticoid receptor antagonists with proven kidney or cardiovascular benefit in adults, so that they don't actually give the name, even though there's only one right now, and who have albuminuria greater than 3 despite maximum tolerated RAS inhibition, start a non-steroidal MRA. And they state that steroidal MRA may be used for treatment of heart failure or hyperaldosteronism or refractory hypertension, but may cause hyperkalemia or reversible decline in GFR, particularly among people with low GFR. So they do not recommend spironolactone as a replacement for finerenone. These are completely different indications. And one of the common side effects with finerenone is hyperkalemia. Now, these individuals are most often already on an ACE or an ARB, and they have kidney disease. They might have diabetes. All of these are risk factors for hyperkalemia. So before starting finerenone, we need to make sure that we've had a recent potassium and that it's being monitored afterwards. If the potassium is less than 4.8, the recommendation is to initiate finerenone at 10 milligrams daily if the GFR is 25 to 60, and you can start at a higher dose of 20 milligrams if the GFR is higher. And then to monitor the potassium at 1 month after initiation, and then every 4 months. And then increased dose 20 milligrams daily if the potassium is acceptable and they can tolerate. And those with a potassium of 4.9 to 5.5 and they're already on finerenone, it can be continued at their current dose, but continue to monitor the potassium and discuss potassium reducing strategies. And in those with the potassium higher than 5.5, the finerenone should be held and consider other adjustments to see if it can be re-added later. And we'll talk about some of those things a little bit later in the talk. And then glucagon, GLP-1, sorry, what I wrote there, are also effective in reducing chronic kidney function decline in those with diabetes and CKD. And KDIGO recommends starting them in those who have diabetic kidney disease who have not achieved individuals' glycemic targets despite use of metformin or SGLT2 inhibitors, although I would argue that it could be started even prior to metformin in those who have diabetic kidney disease. And this is based on the FLOW trial. And the FLOW trial was 3 years. And the results of this trial demonstrated that the number needed to treat to prevent 1 MAKE, which is major adverse kidney event, is only 20. To prevent 1 major cardiovascular event is only 45. And to prevent 1 death from any cause is 39. And semaglutide was the GLP-1 that was used in this trial, and it saw a reduced rate of eGFR decline by 1.1 milliliters per minute per year as compared to placebo. And in the nephrology community, that is very significant. Now, getting past individual classes that reduce albuminuria and kidney function decline and also have cardiovascular benefits. Then we have just other measures to reduce cardiovascular risk reduction, including hypertension management. And I'm not going to go into this talk at individual different agents, but kind of just review the KDIGO guidelines. And that is, they actually recommend targeting a systolic blood pressure of less than 120 when tolerated when using standardized office blood pressure. Now, I don't know if I have it in here. I don't. Now, I would argue that many individuals are not using a standardized office blood pressure. A standardized office blood pressure requires that an individual come in and they're seated for at least 5 minutes, that their bladder is empty, that the room is quiet, that neither the person measuring the blood pressure nor the patient are talking, that the arm is at the level of the heart, and the feet are flat on the floor, and the back is on the back of the seat. Legs are uncrossed. I think even in the most well-intentioned trained clinics, this doesn't happen very often. And it's potentially hazardous to apply the recommended systolic blood pressure of less than 20 when obtained in a non-standardized manner. So personally, I use a target of 130/80, but I make sure that the blood pressure that I'm telling it needs to be less than 130/80. 133 is not a target, 135 is not a target, but less than 130. If you're sure that you're using a standardized office blood pressure, then it's reasonable to use a target of less than 120/80. It's also important that even as nephrologist, I'm looking at lipid lowering therapy. Now, I know that there are new lipid lowering therapy guidelines from American College of Cardiology out actually just recently. These are the KDIGO guidelines, which are older, which recommends in those greater than 50 with an eGFR less than 60 not on dialysis, that individuals be treated with a statin or statin plus ezetimibe. And so essentially, almost all individuals with chronic kidney disease, or certainly all individuals with chronic kidney disease greater than 50. And those greater than 50 that have kidney disease, but their GFR is above 60, also recommend treatment with statin, but the level of evidence is a little bit lower at 1B. And then in those from 18 to 49 with CKD, but not treated with chronic dialysis or kidney transplantation, starting a statin in people with one or more of the following. So coronary artery disease, they should really already be on one. Diabetes, prior ischemic stroke, again, should already be on one, or 10-year incidence of coronary death of non-fatal myocardial infarction of greater than 10%. Feel free to use the prevent calculator as the ACC recommends as well. Actually, they have kidney disease. They're still going to recommend a statin. Now, we talked earlier that several medications that have proven cardiovascular and renal protective effects increase potassium, and potassium is high potassium is already a problem in those with advanced kidney disease, particularly in those with with diabetic kidney disease because of hyporeninemic hypoaldosteronism. And so we should be discussing medical management of hyperkalemia in our patients. Now, in somebody with earlier stages of chronic kidney disease, they may not need any dietary potassium restriction, but many individuals will eventually. We can use things like loops or thiazides to cause kaloresis and allow us to stay on other medications with cardiovascular and renal protective effects. There are several potassium binding resins on the market now, and avoidance of constipation because we also eliminate potassium via the gut. We have kidney dietitians, and I would encourage you to use them as well in your patients with chronic kidney disease and hyperkalemia. But before I can get them to see the dietitian, I will often give them some resources from National Kidney Foundation as a start before they get there. And I like the resources from National Kidney Foundation because it's not just a list of things that they can't have. Nobody wants to hear all the things that they can't do. Instead, there's a list that shows them some high potassium foods that they should avoid and what are some lower potassium alternatives. Also in this handout, which you can find at this website down here, it shows individuals how to read a food label because, to be honest, we're using a lot of packaged foods. So anything that has less than 100 milligrams of potassium per serving is considered low in potassium. Anything more than 200 is high. Now, you could make something in the medium range high if they're having many servings, so they need to look at their serving sizes. And then there's some high potassium foods that those who have hyperkalemia or borderline on hyperkalemia and you're starting a medication that may increase that should avoid or reduce, including things like bananas, melons, oranges, avocados, pistachios are particularly high. And then here's a list of fruits and vegetables that are acceptable, like apples, asparagus, blueberries. We can also use potassium binding resins in order to allow individuals to stay on classes of medications with cardiovascular benefit, as well as sometimes to even liberalize diet. The biggest problem with potassium binding resins is cost, particularly in those with don't have commercial insurance. I do not use K-oxalate, which is in this first column here for chronic hyperkalemia. This to me is like a urgent effort to reduce somebody's potassium in those who I cannot get patiromer or Lokelma. I do not have to use this very often. We prefer not to use K-oxalate for a couple reasons. One, the time to onset is variable, and they have to have a bowel movement in order for it to have worked. And so it can be hours to days before that happens. And it's not tolerated very well. Individuals don't like the GI side effects. And there are some very serious adverse side effects that are not common, but they happen, which is colonic necrosis. Now, patiromer and Localma are both approved for both acute use and long-term use. And so this can be something that somebody is on daily. Patiromer exchanges calcium for potassium and also binds to magnesium. So before starting, if I'm using it chronically, I check a magnesium level. I'll replace it if I need to. It works as soon as 7 hours, so it can also be used in the urgent setting. I wouldn't say emergent. And the binding site is in the colon. It can cause some constipation, diarrhea, flashbacks, but otherwise, I haven't had a lot of issue with individuals tolerating this medication. My biggest issue is cost. And when using on a daily regimen, you can use I usually start with 8.4 and go up to 16. Localma binds potassium in exchange for hydrogen and sodium. And its time of onset is about an hour. And so we have this on formulary. I think most hospitals have it on formulary now for even acute hyperkalemia and severe hyperkalemia. It works very fast. It binds the entire intestinal tract. Again, typically tolerated pretty well. Can lead to some constipation or diarrhea. I haven't had anyone stop it for that reason. Typically, when I have people stop it, it's again because of cost. Uh, Localma, I would say that I use more often, in part because we have it on hospital formulary. But when used daily, it can be 5 to 10 grams daily. And then we're going to move on to anemia and chronic kidney disease. And at the end, we're going to get back to a couple questions that will go back to medication management and potassium. So anemia is very common in those who have chronic kidney disease. It occurs from multiple different reasons. One is from decreased red cell production. And we typically think of this as a relative erythropoietin deficiency. So the kidney, it makes the hormone erythropoietin that tells bone marrow to make blood. And the erythropoietin levels do not appropriately increase in those who have advanced CKD as the hemoglobin decreases. Inflammation, infection, all more common in those who have advanced chronic kidney disease. Hyperparathyroidism can also contribute to this. And individuals with chronic kidney disease can also develop any other nutritional deficiencies like B12, folate, and iron deficiency. And then depletion of circulating red cell pool. And from chronic blood loss, there's increased risk of GI bleeding in those with chronic kidney disease. Reduced red cell circulating half-life, and this is because of uremic toxins. So this more commonly happens in those with advanced kidney disease and those on dialysis, and frequent blood sampling, particularly in those with advanced CKD. And this slide here just shows the complexity of the mechanisms that lead to anemia in those who have chronic kidney disease and the different ways that this can and sometimes can't be addressed. Hepcidin levels are also affected in chronic kidney disease because of inflammation, leads to reduced renal clearance, and then there's also decreased erythropoietin production. So sometimes in the nephrology clinic, we'll actually give different erythrocyte stimulating agents. This is not something that we would want or expect a primary care physician to do. And then we also measure iron levels and give iron when appropriate. There isn't a lot that we can do to address the shortened RBC survival, and uremia in advanced CKD is common and reduces RBC half-life. This is a rather complicated looking algorithm for those who have anemia with chronic kidney disease. I would think that it's probably not that much different than what primary care guidelines suggest, except the iron deficiency guidelines are going to be different. Oh, sorry. And so trying to get this out of the way. And so anyone with anemia and CKD should be screened for iron deficiency and anemia. And anemia is diagnosed by the same guidelines, a hemoglobin less than 13 mn, less than 12 in women. If there is severe iron deficiency anemia, then we should evaluate for a source of bleeding and treat the iron deficiency. Now, and those with iron deficiency not receiving dialysis or peritoneal dialysis, we use these guidelines for consideration of iron treatment in those who have chronic kidney disease. So if the ferritin is less than 100 and TSAT less than 40%, you may consider oral iron. Or a ferritin less than 300 and a TSAT less than 25%. In those receiving dialysis, a ferritin less than 500 and a TSAT less than 30%. I can tell you though that dialysis units will have maybe slightly different guidelines for those receiving hemodialysis, and it's very unit specific. So in those iron deficient based on these guidelines, we're making iron treatment. If they're not iron deficient, then we should be doing a full anemia screen to look for other causes of anemia. I'm not going to go through all of this, but we want to make sure that we're evaluating, particularly in those with CKD, for like an M protein, folic acid, B12, particularly in those who are on dialysis, because dialysis removes water-soluble vitamins, and just a general anemia workup. And then it referred to a hematologist if find nothing. The goal of treating anemia in chronic kidney disease is primarily improvement in quality of life and avoidance of blood transfusions. And avoidance of blood transfusions is essential in this group, in part because of potential transplantation and avoidance of desensitization. When we do iron repletion in those who have non end-stage kidney disease, so not yet on dialysis, we'll typically start with oral, but it's acceptable to switch to IV if there's no improvement after 1 to 3 months or they're unable to tolerate oral. There are many different IV formulations. Here we switch often from Venofer to Infed, and I'd recommend using what you have in your local institution. The KDIGO guidelines state that you don't have to do a test dose, but often I'll find that's institutions dependent as to whether that occurs. And then ESAs, which really should be, if you're getting to this point, they should be prescribed by a nephrologist. They should be started after an individual is iron replete, if the hemoglobin remains less than, our cutoff is about 9. KDIGO just recommends, they don't actually give a threshold for initiating ESAs. They just say they should be considered in the presence of symptoms attributable to anemia, and considering the potential risk versus benefits and harms of RBC transfusion. And they do state that when starting, that you should avoid hemoglobins greater than 11.5, and that's because of adverse outcomes. And so we'll check hemoglobin monthly, sometimes when starting, actually twice monthly. If there's more than a gram increase over a month, we'll reduce the dose to avoid overshooting their hemoglobin. And then the last complication of chronic kidney disease that I'm going to talk about today before I get into a couple cases is metabolic acidosis management. And it's really, if somebody has metabolic acidosis from their chronic kidney disease, they're really at a point that they should be seeing a nephrologist. But I do think it's important that primary care physicians kind of have an understanding of when these medications are started, what their indication is for, and what they do and do not accomplish. And the guidelines suggest were actually updated within the last year, and they recommend not treating based on a single value, but evaluating a trend. We'll often see maybe a value go down to 18, and the next time we check it's 22, and we wouldn't necessarily treat that single 18 value. In trials, oral sodium bicarb does not consistently prevent kidney events. So we used to think that by giving individuals bicarb and targeting a level of, say, 22, that we were reducing rate of CKD progression, but that hasn't panned out. Um, and then the KDIGO 2024 practice point is actually and it's a practice point, not a recommendation or a guideline, is to consider pharmacologic and or dietary intervention to prevent development of acidosis with potential clinical implications. So their suggestion is starting with a serum bicarb less than 18, which is a lowering from their previous guideline of 22. There are multiple different pharmacologic therapies for metabolic acidosis, the most common being oral sodium bicarb tablets. One tablet has 650 milligrams of sodium bicarb. It's 8 milliequivalents of bicarb. But individuals can also use baking soda. It's 100% sodium bicarb. An eighth of a teaspoon is the same as a 650 milligram tablet. And so if I'm using baking soda for whatever reason, I choose to use baking soda over tablets, usually it's patient preference, then I would start with a quarter teaspoon dissolved in water daily. Potassium citrate, although citrate is metabolized to base in the liver, is not recommended for metabolic acidosis in those with chronic kidney disease, primarily due to risk for hyperkalemia. We use it usually for stone prevention. And all of these therapies, the side effects can be belching, bloating, and nausea, belching being the most common. And then diet can also affect the bicarb levels. In general, animal proteins are metabolized to acid and plant proteins are metabolized to base. So a plant-based diet, including like fruits and veggies, including apples, apricots, oranges, peaches, pears, raisins, some of these are high bicarb fruits and veggies, will also demonstrate an increase in the serum bicarb. In two randomized control trials, fruits and vegetables had similar improvements in bicarb levels. I would like to point out, though, in this randomized control trial, this was individuals with non-diabetic kidney disease and did not have pre-existing hyperkalemia. I wouldn't start recommending this diet to all of your patients with kidney disease without guidance on avoiding high potassium fruits and veggies. And dietary interventions are reasonable in those who do not have hyperkalemia. But I would suggest the guidance of a kidney disease dietitian when we're using fruits and veggies to manage metabolic acidosis. So I want to go back and do just kind of a couple case vignettes. These are common things that we see in the clinic. And so this first one, we have a 55-year-old female, and she has non-diabetic kidney disease. Her GFR is 28, so CKD 4. And her UACR is 350 milligrams per gram, so above target, right? Our target is less than 30. Her blood pressure is normal, 124/76 on valsartan, 320 milligrams daily, and dapagliflozin and nifedipine. Her potassium is high at 5.6, and there's trace edema on her bilateral lower extremity. So, sorry, a lot kind of going on in the question. In addition to low potassium diet, which of the following would you recommend? A is reduce valsartan to 160 daily and monitor blood pressure. B is discontinue nifedipine and start chlorthalidone. C, add Lokelma. D, add finerenone. Or E, add Bumex. And I'm going to give you just a little bit to kind of think about what you would do. You don't have to answer. And I'll go through each of these and kind of tell you what I would do and what I would think. So to point out a couple things from this problem stem is that we have an individual who has kidney disease, stage 4. Her albuminuria has not been at target. Her blood pressure is controlled. She's on max ARB. She's on an SGLT2 inhibitor, which is great. And also nifedipine, but her potassium is high and she has a little bit of edema. And so we want to be able to keep this individual on max ACE-ARB because we know that it reduces cardiovascular mortality and cardiovascular events. And so we don't want to do A, which is reduce valsartan. Although I think this is what commonly is done. We don't, C, we could just add Lokelma at 10 grams daily. It would reduce the potassium. It wouldn't do anything for her bilateral lower extremity edema, however, and I think there's simpler solutions. D is add finerenone, and finerenone would reduce the protein in the urine, but it would also increase her potassium. It would be potentially dangerous to add right now in this individual. And Bumix would reduce the potassium from kaloresis and would address the maybe the lower extremity edema, but I do think that it it could lower the blood pressure some, and I think there is still one better solution, and that would be B, discontinue nifedipine and start chlorthalidone. Now, we used to think that chlorthalidone is not effective in those with advanced kidney disease or CKD stage 4 for blood pressure control. There has been a trial since that does demonstrate that chlorthalidone is effective. Chlorthalidone will cause kaloresis and reduce the potassium in the blood. It will also get rid of the calcium channel blocker associated edema and get rid of some salt, which also can improve her edema. So I would go with B if I were seeing this patient in clinic. And then ideally, I would bring the patient back afterwards, recheck what their potassium is, and see if they can add finerenone on from now if their UACR isn't at target then. But I want to keep them on that ARB. Any questions about that one? Okay. Then this next one, we have a 50-year-old male with diabetic kidney disease. His GFR is 35. His UACR is 500. And he is on lisinopril 40, amlodipine 5, and also metformin, insulin, and a statin. His office blood pressure is above target, is 145/85, and his serum potassium is normal at 4.6. What do you recommend next for blood pressure control? And I'm just going to kind of go through all of these. 1 or A, add chlorthalidone, 25 milligrams daily. And that certainly wouldn't be wrong. You'd get better blood pressure control. B, increase amlodipine to 10 milligrams daily. Also could work. With A and B, though, you're not going to do anything to reduce the albumin creatinine ratio, and so it doesn't address that. C, add empagliflozin 10 milligrams daily. It will help the UACR. It may help the blood pressure a little bit, probably won't get it to target. D, add finerenone 10 milligrams daily, and I would argue it will again help the UACR, but won't get the blood pressure to target. Or E, add empagliflozin and finerenone. And I would do E. I would get this individual on all of the medications that help reduce the protein in the urine. They both have a little bit of blood pressure effect, and then reassess where the blood pressure is to see whether any other intervention is needed from there. And I would start them both at the same time. There's no reason that this person can't start them both. The blood pressure will tolerate it. The potassium is 4.6, so it's acceptable to start finerenone. Ideally, they would have already been on a SGLT2 inhibitor, but now's the perfect time to start. And again, we showed previously that SGLT2 inhibitors on average reduce systolic blood pressure about somewhere between 5 and 8. And I didn't show you the data for finerenone, but it's closer to 3 or 4. And so I would do them both together. So then getting to the question, when do you refer to a nephrologist? And again, I think the algorithms for referring to nephrology continue to get more complicated. And so I like to think of it in a couple different ways. The first appears the causes. If you have a patient with chronic kidney disease and you're not sure why, particularly a young individual, you don't think they should have chronic kidney disease, or it's not, they don't have diabetes, or there's a risk of hereditary kidney disease, including, say, APOL1, or they have recurrent or extensive nephrolithiasis. Individual where you're kind of scratching your head, I don't understand why this patient has kidney, they should see a nephrologist. And then we look at the eGFR and risk of kidney replacement therapies, and there's some calculators for this I'll show you next. For a 3 to 5% 5-year risk of requiring kidney replacement therapy measured during a validated risk equation, or those with a GFR less than 30, or a sustained GFR of greater than fallen GFR greater than 20 or 30% in those people initiating hemodynamically active therapies, refers to nephrology. In those who have albuminuria or microscopic hematuria, so let's say you have them on an ACE or an ARB already, they have diabetic kidney disease or other therapies in their UACR remains above target. Again, another good referral to nephrology. And then in those who have complications from their chronic kidney disease, or those who have hypertension refractory to treatment. I wouldn't say that they have to be on 4 antihypertensive agents because some individuals just have difficulty tolerating medications. That could be another reason to refer. Persistent abnormalities of serum potassium, acidosis, anemia, bone disease, or malnutrition. Again, a referral to nephrology. I think the big thing here is, and those who are at risk of progression, so persistent albuminuria, and certainly those where the CKD etiology is not clear, they should see a nephrologist. This is the equation I was talking about. It's the kidney failure risk equation. And the way that I use this in clinic is actually, so sometimes I get individuals who are elderly and they have chronic kidney disease, stage 3A, and they don't have any protein in the urine, but they're very worried because of the diagnosis of chronic kidney disease. And I might actually use this equation to show them that their risk that in their lifetime, in the next 5 years, that they're going to require dialysis is very, very low. But it can also be used as a tool to decide when to refer someone for nephrology or as a nephrologist, when to refer somebody for vascular access. And so long as you have their age, sex, GFR, and their UACR, you can plug these in here. This is an example. This is a 83-year-old male who has 30 milligrams per gram of albuminuria, and his GFR is 42. This is actually where I would use it most, is to reassure patients that are lower risk of progression. And so this comes up with a 2-year risk of requiring dialysis of 0.5% and, at 5 years of 1.5%. So this individual's risk is very low. And so in conclusion, chronic kidney disease affects multiple systems, and the most common cause of death is cardiovascular disease. And I hopefully after this, what we all know now is that all the key medications for slowing kidney function decline and prevention of cardiovascular mortality in our patients with chronic kidney disease. Any questions?
Feel free to unmute to ask questions or pop them in the chat. I did have a question for you, Dr. Sohaney, around, you mentioned a couple times about the cost of certain medications being a barrier. Are there any particular tips that you can share on accessing some of those medications, or I don't know, special programs that you use to help your patients get access to those?
Yeah, I use pharmaceutical coupons a lot in those who have commercial insurance. A lot of my patients have Medicare or Medicaid, and they do have to follow the guidelines or the Medicare guidelines. And so if I'm very persistent with the appeal process, I've been able to get things approved, at least finerenone. That's probably the one where I have to do the most appeals the most. I don't have issues with SGLT2 inhibitors any longer, and never have issues with ACE or ARBs. What I do have issue with is the potassium binding resins, because the insurance company guidelines for their use is quite high. They'll often require that they have 2 consecutive values of hyperkalemia, that they demonstrated that they're on a low potassium diet, and there is something else in there. But to get the 2 consecutive values that are above their threshold, I often don't want to wait until that. I haven't found a good solution in that scenario in order to get it covered. That's the case where I'll go to Lokelma for urgent use and use things like loops or thiazides and low potassium diet to try to get them there. I don't think we have a lot of great internal resources where I'm at in order to get those covered because they are quite costly. Yeah. If you have resources, though, I'd love to hear about them.
Well, I do know of another resource, particularly for GLP-1s and SGLT2s, if that's an issue. And there's a collaborative called the Michigan Collaborative of Type 2 Diabetes. They've come up with a lot of great resources, particularly around diabetes, right? But a lot of those meds are also used in chronic kidney disease. So I will go ahead and share that in the chat as well. In terms of like prescription assistance programs and other ways to get things covered.
Yeah, and I should add the GLP-1 inhibitors, they don't often have an issue in those who have diabetes, but there is evidence of slowing kidney disease progression, even those with non-diabetic kidney disease, and that is where I have a big issue at getting coverage. Um, Perfect. It was wonderful speaking with everyone today. Feel free to reach out afterwards if you do have any questions.
Okay, thank you, everybody. I'll be sure to send that in an email, the MCT2D resource as well. Thank you so much for your participation.
Thank you.
And thank you, Dr. Sohaney. It was wonderful. Appreciated the case studies too. Those were a little hard for me, but very, very interesting to see kind of thinking about, multiple conditions that these meds might influence.
Yeah. Thank you.
Have a great day.